Hello, dear colleagues. My name is Dr. Hisham Hussein Khalil, intervention cardiologist, cath lab director in Saudi Babtin Cardiac Center. It's my pleasure to share with you this challenging case under the title of Combined Coronary Rotablation and Lithotripsy for Heavily Calcified Coronary Lesions Treatment Optimization. 52 years old female, diabetic, hypertensive, dyslipidemic with morbid obesity. 2 years ago, she had stroke with right-sided hemiparesis, very limited mobility, old DVT. Lately, in the last 2 months, she complained of typical anginal chest pain on minimal exertion, admitted in another hospital with non-STEMI and referred after doing coronary angiography, which showed heavily calcified coronary artery and totally occluded LAD, severely stenotic RCA with calcification, referred for bypass surgery. Her coronary angiogram showed patent left main and patent LCX, diffuse diseased OM, totally occluded calcified LAD, calcified RCA with distal significant disease. Her echo showed moderate LV dysfunction, diffusely hypokinetic multiple segments, ejection fraction 38% no valve lesion. During heart team discussion, the three options were discussed: medical treatments, CABG, and high-risk PCI. As the lady is currently symptomatic on full medical treatment, so this option were not valid. Bypass surgery, the following were considered: high risk for surgery, the prior stroke, morbid obesity, limited activity and fragility. The patient herself and the family were preferring to avoid surgery. Her syntax score were 44, PCI calculated 4-year mortality 20%, CABG 4-year mortality 1.5. Her Euroscore gave us a 38% of MACE rate. The case was rejected by surgical team and high-risk PCI were planned for this heavily calcified lesion. First stage were PCI for RCA. The approach was transradial 6 French guiding catheter AL1, pilot 150 cross to the distal RCA, pre-dilatation with small balloon 1 and then upsized up till 2.5 balloon, and end up with non-compliant balloon pre-stenting. 2 stents were deployed, 225 by 19, 25 by 29, covering RCA lesion from mid to distal. Final TIMI3, good result in the RCA, and we went for the second stage. For another admission, BCI were done to the LAD. The approach was transfemoral approach, 7 French guiding XB3 with a guideliner extension. Cyan blue guide wire successfully crossed to the distal LAD. Pre-dilatation using 1 balloon, then upsized to 2 mm normal balloon, which gave us a chance to cross a super cross microcatheter and wire exchange to a rotawire. Multiple atherectomy were done using 1.5 and 1.25 started, 1.5 upsized for proximal, mid, and distal LAD, followed by pre-dilatation of a non-compliant balloon with 2.5. This is post-atherectomy angiogram, patent LAD. IVUS pullback from distal to proximal showed less calcification at the distal with severe atheroma with scattered calcification. Mid-LAD showed significant calcification, and proximal LAD showed full arc of calcification, which will hinder the stent deployment. So the option was to go for a calcification modification of this proximal to mid-LAD using the intravascular lithotripsy method, using a semi-compliant balloon, 3 by 12. The AVL balloon inflated to 4 atmosphere, and then 80 pulses were given along the entire proximal to mid-LAD. And each time after the 10-second cycle, the balloon were inflated to 6 and then deflated. These were repeated to 8 cycles along the entire length of the proximal to mid-LAD. Then stenting were easily deployed. Distal LAD received 2.25 by 30, mid-LAD 275 by 33. And proximal LAD had 3.5 by 33 stent with kissing balloon with the circumflex. And this is the final. TIMI-3, good stent deployment in the entire length of the LAD. IVUS also showed well-deployed stent from the most tight proximal and mid-LAD with reasonable minimal human area. The hospital course of the patient were 12-day. Complication were major groin hematoma in spite of the use of the angioceal closure device. CT showed contained groin hematoma with minor retroperitoneal extension. Conservative treatment was our option, and the blood transfusion were given for 2 bagged RBCs. Discharge hemoglobin was 9.2. Her renal function were normal over 3 samples post procedure. The patient was contacted in OBD virtual basis during the COVID pandemic, and the patient was asymptomatic stable with no evidence of further bleeding. So in this case, the take-home message were considering the treatment of coronary calcified lesion is a real challenge with high risk of serious complication. The optimal therapy for calcified lesion is usually multi-adjunctive in the new era, with several strategies that should be available in cath lab laboratory. Increased understanding of calcification by using imaging tools, OCT or IVUS, will individualize the treatment regimen and will contribute to the successful outcome. Combined atherectomy, lithotripsy, method of treatment may revolutionize this indication, but we have to consider the cost effectiveness of this advanced technology, and this will be needing to consider it in the future. Thank you and stay safe.